Okay, so since it's 12:03 and we have a busy agenda today, I'm going to dive in. Thank you all for being here. It's great to see some very familiar faces and names. So first, I'll start with going over kind of what the agenda of the session is going to look like. We'll start with a few updates about Atlas. We know that you're hungry for some new information. We'll give you an overview of the Addiction Treatment Continuous Quality Improvement or Learning Series, or the Addiction Treatment CQI Learning Series itself. We'll have presentations from our speakers, Dr. Victor Capoccia and Kevin Norton, and then a bit of discussion, and then just final thoughts and upcoming events in the series. So as a note, you'll be muted during the presentation for most of it, though we may open the lines for you to contribute. If you have any questions at any point, as I mentioned, please feel free to drop them in the chat and we will respond there. Also, there will be several opportunities for you to add your thoughts to the chat. So throughout, Kevin and Victor will ask some questions, and we really invite you to get involved. We don't want this to just be us talking at you. And as I said before, this session is being recorded, and both the slides and recording will be made available after the event. And so with that, we can dive into our Atlas updates. So as you know, treatmentatlas.org launched on July 21st. If you missed it, we had a great launch event. We had over 900 people attend. We had speeches by the Surgeon General, by the Director of ONDCP, and by our moderators, our ambassadors, a really exciting event. We invite you to see it, to go back and look at it. In terms of what we're seeing on the website traffic, I know this is of a lot of interest to people. So as you can see here, we've had over 30,000 unique visitors since we launched in July, and over 37,000 sessions. So a session means that it could be one person visiting the site multiple times, whereas a unique visitor is just one person. And then we've had over 1,000 people take the Addiction Treatment Needs Assessment, which, as you may recall, is a brief 13-question assessment. It allows a person to assess their or a loved one's most appropriate type of treatment. So whether that's outpatient, inpatient, intensive outpatient, or residential. And as a reminder, that assessment does not take the place of a clinician's assessment once somebody starts treatment, but it is great help in helping people understand where to really start their search. On the left, you'll see the number of sessions by state. And kind of in terms of trends that we're seeing lower traffic on the weekends, and most traffic is coming through Shatterproof, different kind of the ways that we've been promoting the website through paid search, through advertisements on Google. But we really hope that in the coming months, this will transition to be more from community organizations. We're currently working with our community organizations to help get the links to people who need it, whether that's on a resource page, whether that's on a large treatment provider association's website. So we can talk more about that at the end, or feel free to message us your thoughts around that. As another big update, the password protected portals will be launching in the near future. We should be sending you an email in the coming weeks. And so in terms of what to expect when those portals launch, your facility's point of contact will receive an email with your facility's portal login. And so as a reminder, this is the kind of back-end portals that people can use to view their facility quality data and state averages, view patient feedback and state averages. They can also download those data if you'd like to do your own more detailed analyses, and you can flag any patient reviews that violate the Atlas terms of service. And so in terms of the immediate Atlas team priorities, now that we've launched, we're kind of approaching many different foci, I'd say. We want to sustain Atlas in our phase 1 states. We want to raise public awareness of the platform, and we want to support quality improvement. And that's what our team has really been working towards this month and over these coming months. And so for today, we'll be focusing on the support quality improvement piece. And with that, I'll turn it over to my colleague, Leah Kaufman.
Great, thank you, Carolyn. So as Carolyn mentioned, we're very excited to be moving into our clinical quality improvement learning series, which is the first step in the quality improvement efforts that we're working on throughout the 6 pilot states. The goal of the technical assistance work is to empower and support providers in building quality improvement infrastructures. I know we have some exciting speakers today that my colleague Angad Batar will introduce in a moment, but wanted to walk you through the goals of the technical assistance. A key challenge for Shatterproof and partner states is determining how best to support providers. I know we've talked with you at various provider roundtables over the past year about kind of this end goal once Atlas is launched of ensuring that we're supporting providers with appropriate training, providing resources and assistance to address the identified improvement aims as you start to look at the data available in the Atlas password protected portals. To accomplish this, we have developed a technical assistance plan. So it will build on some of the trends we're seeing in Atlas that we've shared with you in the past few months, and support providers in adopting policies and workflows that align with the evidence-based best practices outlined in Shatterproof's National Principles of Care. The plan will include live and on-demand webinars. So you're at the first one. We're excited to have such good attendance today. Along with these events, which will be monthly, there will also be related electronic resources. These will be developed both by Shatterproof and external speakers. So you'll start to see some of those resources on the provider resource page within Atlas. If you hadn't had a chance to take a look at that, definitely go, and you can find it in the top search bar in the drop-down menu. So check out that provider resource page. We want to move to the next slide. We'll talk about some of the core topics we have coming up.
Great, thanks, Leah. So we have obviously the event today, and we're looking forward to hosting events in October on comprehensive care delivery and addiction treatment. In November, we'll be talking about increasing the use of the ASAM dimensions of care. And in December, we'll be leveraging patient experience feedback to help improve operations. So for the October session, I think we have finalized the speakers, and we'll be sending the invitation here very shortly, so please stay tuned. And as Leah mentioned, we'll have resources that will take shape in many different ways, so electronic methods. We'll also be sending out a state-by-state fact sheet for medications for opioid use disorder. And along with that, we're hoping to create case studies that will really sort of highlight how states can leverage the Atlas data to drive quality improvement. Next slide, please. So Leah, I'll turn it back to you.
Thank you, Angad. So looking at the participation rates from state to state, the technical assistance webinars will be open to any provider within the 6 pilot states. That being said, we're excited to provide the access to those password protected portals in a few weeks here. So those of you who submitted the treatment facility survey will be able to look at the trends in your data, and we'll be able to capitalize upon some of those sessions in the coming months to start targeting quality improvement efforts. Next slide.
All right, well, thanks, Leah. So now I would like to introduce our distinguished speakers, Dr. Victor Capoccia and Kevin Norton. And I would like to give a little bit of background on both. Dr. Capoccia is an independent consultant, and his career has spanned academic, philanthropic, and public and nonprofit management positions in health and in the human services field. As an academic, he taught graduate planning, organizational change, and research at Boston College. And as a manager, he directed the City of Boston Health Department and was CEO of a community-based addiction prevention and treatment agency. In philanthropy, he has led efforts to improve quality and access to addiction and related health services at the Robert Wood Johnson Foundation and the Open Society Institute. Kevin Norton is the Chief Operating Officer for Centerstone, a large multi-state nonprofit behavioral health provider. Kevin started in the field as a clinician, working in a short-term intensive treatment program and a recovery house. Kevin has worked in comprehensive health systems, leading the behavioral health divisions. Today, Kevin's focus at Cornerstone is on growth, access to care, and quality. So without further delay, I'd like to hand it over to Dr. Capoccia and Kevin Norton.
Thank you, Angad and Leah and Caroline.
Victor, you're muted.
Thank you. Let me start again. That's Leah said we had exciting speakers, and I thought we'd be exciting by being on mute or something. I don't know. In any case, I think what we may not do in terms of excitement by singing and dancing, I hope that we were able to make up for in terms of our commitment and passion for good quality addiction treatment. I want to congratulate Shatterproof for focusing on this issue, for taking this on, and for staying with it over a period of time. The patients that you all are serving, that I've been involved with over many years, can only benefit from this. And I want to congratulate the participants. There are 120 apparently on at this point in time, because you are in effect early adopters of this system, which I'm sure will grow. Among you, there are people obviously representing 6 states and more. From what we understand in terms of your registration, about 1/3 of you already have strong quality improvement systems. Another half reported that you have some experience in this area. Just a bit fewer than 20% said that this is introductory material. So in effect, this is a challenge for us to be able to talk with you across a range of experience. But I think that challenge is really mitigated, and we're able to do this because within the audience, those of you with significant experience can help, we can learn from each other. And I think that learning from each other goes across all 3 categories. In addition, I've noticed in the audience, there are colleagues with very deep experience. Tommy Bauer was among the earliest adopters of the NIATEX system, the quality process improvement system that focused on increasing admissions and access to care, as she was responsible for quality at SUD Treatment Center. Frank McCrory, Frank, it's been eons, but Frank from New York was at Oasis in New York and was one of the earliest adopters of the movement to improve quality in addiction treatment by being a part of the earliest convenings in 1998 of the Washington Circle Group, something I'll make a reference to later. There are many others I know that are registered. There are trade association folks that represent you in the audience. Connie Peters, we're glad that you're here. And I want to be able to draw on not only those that are colleagues, but those of you who I haven't had the opportunity to meet, but who have significant experience or who have significant questions in terms of what you're doing, so that we make this as interactive as possible. Ultimately, 2 other points. One is, this is an opportunity for you to learn from each other. And the second is, as Leah pointed out, this is the first of a series. The next slide, please. The next. So I hope as a result of the time that we spent together today, that you will come away with, in effect, 4 takeaways. One is that we use data, and that we use data to understand the patient, and that we use data to understand our performance. And that the beginning point and the focus of, why are we doing quality is, in effect, the patient. That's our starting point. Two, that there are, in fact, empirically based standards and measures that distinguish the quality of treatment. I referenced the Washington Circle Group convened by SAMHSA in 1998. That represents over 22 years of experience, and there's been a lot of research in depth that's provided empirically based standards and tested measures in that interim period of time. Third, I hope that you will come away understanding and feeling that there are replicable and doable, practical approaches that you can use to improve treatment. And fourth, I hope that you come away with an opportunity to learn from each other, but also to come away with an understanding that improvement does not imply failure. One of the things that we really need to address and get through is that improving quality carries an implicit dimension that someone did something wrong or there's something amiss. And in fact, it's just the opposite. An open system, a transparent system, is one that reinforces a culture that says we can solve problems and we can do better. Next slide, please. What does quality look like? Okay, this is where you're going to see Victor's a little weird. Quality has many meanings to people. Putting this together, I posed the question to myself, and I have to admit, the first thing that came into my mind was, because maybe it's the end of summer and I like to garden and etc. There's nothing like picking a tomato that's ripe and fresh from your own garden and eating it right on the spot, right? I don't know if you've had that experience, if you can relate to it. If you can't, I'm sorry. Bear with me. I am a bit weird, but anyway, I wonder if you can share maybe on the chat function what quality looks like to you. The next slide, please. And what we'll do is we're going to, as you respond in the chat, we will summarize some of those themes and maybe come back to you and ask you to expand. So why is a tomato fresh picked from the vine where I eat on the spot? Because one, it has an intended effect, right? It tastes like a tomato. We've all been in the aisles of the Kroger's or what have you, you name it, Stop and Shop. And you know those tomatoes in February that are in a plastic tube with plastic wrap around them. There's 4 in it, and that you can use them kind of as golf balls sometimes because they're all the same size. They're very hard. You bite into one of those. It's a little bit different, right? But we'll come to that. So, second, it's available. It's when it's ripe, it's timely, right? It's timely. It's available. It has a value. Right? Not necessarily value isn't dollar for dollar. Maybe it cost me 3 times to grow these silly tomatoes in the garden, although I don't put anything in them. Anyway, it has value because it's not just affordable, but it does what it's supposed to. It's sustainable, presumably doesn't spoil quickly. So if we're thinking about this in terms of, first, intended effect, so the tomato in the plastic wrap sort of tastes like a tomato. Well, in our world of addiction, the parallel to that would be the difference between a person with an opiate use disorder that is involved in a methadone-based treatment program, outpatient program, that you're given a dose of at least 60 milligrams to, right? That's going to have an intended effect. And yet a lot of programs are going to give a person less than 30. Well, that's sort of a treatment. It isn't, it's not going to have as likely the intended effect. If you think about timeliness, the person who is able to call in programs that we've worked with Niatex would have same-day admissions and work to, is going to get engaged because there's an immediate response. And it's not the same. It's not the same as you call and we'll give you an appointment for 2 weeks from now, and maybe and maybe not, you show up. Most likely not. Value, the right dose of methadone has the person feel better. That's value, right? The inappropriate dose of methadone, person is not going to feel well. They're still going to feel partly sick. It's not the same value. And, okay, enough of the tomatoes, right? The analogy isn't perfect. We've got to be sustainable. Next slide, please.
Victor, as we go to the next slide, I thought I would just sort of summarize what we're seeing in the chat in terms of what is quality. So a couple things we're seeing in the chat. Quality is effective and safe patient care. Quality is comprehensive and thoughtful. Someone else stated that they love eating tomatoes right off the vine as well.
I want to talk to that person. No, that's it.
Quality is a culmination of continuous improvement processes. Quality is the best care we can give to our patients. Quality is designed to achieve the best result. And last but not least, quality is a high value, reasonable effort with high reward, where both the service and the recipient of the service see success.
Terrific. Those are great responses. I'd love to hear more, a little bit more from the person who wrote the last statement. But I wonder, let's see. I have to watch and look at time. I guess we're with the person who wrote the last statement about the value spilling over to the organization as well as the person, like to say a little bit more about what they mean by that, or say something about how you know that is the case in your organization. What does your organization look like that's different that allows you to say that? Say it out loud.
Helen.
Yes.
Unmute yourself and say it out loud. Yep.
I was trying to be a good Zoom attendee and keep myself nice and quiet in the corner over here, so sorry. So I think quality obviously should be patient focused, but I think it's important that something that's of value, something that the patient and the staff member both see as success. I don't have to see it in the same way, but I think it's important that both of those perspectives line up to a certain degree. I think high quality care involves feedback to the people who are giving that care, and I think that when they get that feedback from their team as well as their recipients of that care, it improves their ability to continue or even improve on the care that they are giving. So I think it's certainly primarily the flow is to the patient, but I think having supply flow and flow from their management team is important to continue that trend moving forward.
Okay, so Helen said, Helen, the sound went in and out, but Helen said that it accrues not just to the patient, but back to staff and back to the organization. And as you've got into my presentation, Helen, because there is research that supports exactly what you said, that in effect, that a good quality improvement process results in a staff that has higher satisfaction, less turnover. It results in a better bottom line for the organization. There's both financial as well as cultural benefits. So what does this mean for quality in terms of substance use disorder treatment? And particularly, what's it mean for this Shatterproof stuff? Huh? So if we take the 4 categories, intended effect, timely, value, sustainability, and we think about substance use disorder treatment, in terms of what's the effect we're looking for? We want to reduce harm, right? We want to improve the patient's well-being. We want the patient to be able to reach some kind of degree of equilibrium within themselves. We want them connected with their family, with their community in productive ways. So it's quality then to get that intended effect if it's timely. It's quality in terms of timeliness if the patient gets attention immediately, gets a thorough assessment and a treatment plan that's tailored to their circumstances. In terms of value, it's quality if the patient receives evidence-based, both clinical and pharmacological interventions from a staff that is experienced, trained, credentialed, appropriate. It's quality if that's managed and coordinated with other conditions that the patient manifests. It's quality if it's coordinated with other services, if it's continuous. In terms of sustaining, it's quality if there's follow-up with the patient and if the patient remains connected and if recovery is supported. These are the Shatterproof principles. You know, what got me involved in quality eons ago, a long time ago, when I was directed a community-based treatment organization. And by the way, full disclosure, Kevin's residential counselor job was in that same organization. So we have known each other and worked together for all those eons, even though he looks younger than. Anyway, within that context of being responsible for a treatment organization, the number of people who left treatment prematurely, AMAs, the number of no-shows were bothersome. Why was that happening? Were we not offering something that was relevant? You know, and we know those are complex situations. They haven't been totally mitigated today. But if those conditions doesn't drive one to think about what are we doing and what can we do different to really bring those numbers, change those numbers. And there are other dimensions. There's so many dimensions within our field. You know, I from time to time would call our organization from the outside. And I didn't try to be secret. I didn't try to say I was this or that, but I just wanted to know what was what. And so, you know, I get a response in our detoxification center, which was located in the grounds of a state hospital at that time. And, you know, the routine was, we're full, call back between 7 and 10. We're full, call back between 7 and 10. I mean, whether we were totally full or not, that's not exactly an encouraging message to motivate somebody to come into treatment. How many times have you heard, and I know no one here has ever said, and begun a sentence with, "Our philosophy of treatment is," right? You can have a philosophy, I guess, but I'd rather have evidence. I'd rather have treatment that's based not on a philosophy, but based on evidence. But we persist with that. Our philosophy is we don't do methadone. I walked into a residential, some of you have heard this before, but into a residential treatment center in another state one day. There was a patient literally with a cardboard sign around his neck. That sign was attached with twine. And I don't remember the exact message anymore on that sign, but it was one that shamed the patient. It was, supposedly part of treatment that broke them down and built them up. These are things that we need to be able to address. This dimensions of access, assessment, personal treatment plan, evidence-based pharmacological and clinical interventions, managing disease conditions with other related conditions, coordinating care. Those are measurable. They're all data-based. You have information that can help you address them. Next slide, please. For treatment standards and the evidence behind them and what is behind, these are references that you can you can use. Again, I made reference earlier in the introduction to the Washington Circle Group and the folks that put that together, and to their credit, SAMHSA stimulated that in 1998. That was essentially Mady Chalk, who is since retired, but continues to advocate for good quality treatment in this in our field. And Frank McCrory was part of that. Brandeis Heller Group, Connie Hogan, Deborah Garnick, a psychiatrist named John Bartlett, and they began to think through the tough questions of, what does quality mean in our world? How do we begin to measure it? How do we begin to get it accepted? How do we tie it to both entities that provide care as well as have people who purchase care understand what quality would look like? In 2006, the National Quality Forum, which is a congressionally chartered entity that is to set standards for healthcare of all kinds, was tasked through the Robert Wood Johnson Foundation with identifying and developing a consensus document that reflected standards that had evidence behind them for the treatment of addiction. And that was one of the first consolidations of standards that said, here's what care with evidence behind it looks like. That publication is still available for those of you who have not seen it on NQF's website. Today, National Quality Forum has more than 500 endorsed measures related to substance use disorder treatment. The newest standards that they have focus on post emergency department visits, referrals, and screening. ASAM, the American Society of Addiction Medicine, has 9 measures and standards for physicians to follow. they focus and distinguish. It's an interesting distinction between process measures, things like the percent of patients with opiate disorders that receive, or alcohol diagnosis, that receive prescribed medications that are appropriate. That's kind of a process measure. It doesn't tell you if the patient got better, it tells you what you did. And then they distinguish process measures from context measures. So they have, for example, screening for tobacco and psychiatric disorders. That's a process of treatment. Again, it doesn't tell you what the patient is actually doing or benefiting, but it's an indicator of probability that that's a good activity. And they distinguish process and context measures from outcome measures. And outcome measures that they use, for example, readmission frequency to residential or withdrawal management programs. Medicaid, which I suspect is a payer source that is significant to most of you, is focusing measures on continuity of care after withdrawal management and treatment that follows and support that follows pharmacological basis. So what I'd like to do now is go to a specific example and ask Kevin Norton, who was introduced, to present in Centerstone. And I would just say that this isn't here because it's the ideal model and therefore you have to emulate it. It's here because it's a thoughtful model that is in process. And we wanted to be able to say and demonstrate with you that there are programs, including yourselves, that are on this journey. And so you'll have a chance to hear from Kevin where they are on their journey.
Thank you, Victor. Full disclosure, when I was working for Center for Addictive Behaviors and Victor was the president, I was a brand new clinician. And in early 1994, Victor comes into the recovery house with the head of our methadone clinic and talked about the fact that we were going to admit to our halfway house a client who was on methadone. And again, brand new to the field, didn't know a lot. And so I sat there very quietly as staff started yelling at Victor and started yelling at the methadone director as to how crazy this was. And this was antithetical to good treatment. And Victor very patiently and very calmly talked about the science behind people who need multiple interventions at the same time. And I thought, this is going to be fascinating. A few days later, the first client, Frank, walks in the door, and he did okay for a week or so and then blew out of treatment. And it was Victor and the head of the methadone clinic that were paying attention very closely. And then the second client arrived. And Susan actually lived in the house for 4 months and graduated and continued to do well. And that was the first, for me, the first introduction to how we look at both the science and the evidence of what people need and how do we move them forward. And that was back in '94. And that was a pretty crazy, bold move in '94. We still have organizations today that wouldn't make that kind of a bold move, but we want to keep pushing in that direction. So let me do a very, very brief kind of overview of Centerstone just to kind of set the context of the organization. We have major operations in Tennessee, Florida, Indiana, Illinois, and Georgia. Started to deliver some services in North Carolina. We're fairly large by comparison to a number of players. And what that affords us really is some economy of scale and the ability to invest in certain infrastructures that can continue to support the organization. We also deliver services through our military services program across the entire footprint of the US. And one of my favorite features about Centerstone is that we have our own research institute as part of our organization. And there are really two focuses that we have within the Research Institute. One is doing program evaluation on a number of SAMHSA grants that we have. At any point in time, we have approximately 20 SAMHSA grants spread out across our footprint. And so we have our in-house evaluators. But more important than that is that we have a number of scientists who, one, understand evidence-based interventions and develop trainings for our staff to become well-versed in evidence-based interventions. And then we also have staff whose area of focus is implementation science. You know, change is never easy for our clients. It is just as difficult for our staff. And so using scientists to help us be successful in how we implement new programs or implement new workflows or look at different measures across our footprint is one of the things that really makes some of the work that we're doing fairly unique. And what we're really doing is looking at what's going on across the field and figuring out how do we consolidate it, and then how do we standardize it within our organization. We can flip to the next slide. So our quality department really is a system-wide department. It now rolls up into the board. Our parent board looks at all of our quality measures, monitors both the outcomes as well as the processes that we've got in place. I happen to have the really great role of being the executive champion. And I mention that because there are times in every organization where we get stuck. We get stuck because we're doing things the way we used to do them. We get stuck because we're doing things the way that someone told us to do it 10 years ago. And it sometimes takes somebody to raise their hand and say, we're going to do it differently. And having an executive sponsor who really believes in quality and values it allows you to push through some of those typical change processes and challenges that we see. And so because we have a fairly broad geographic span, we have members from every one of our state operations sitting as part of the Enterprise Quality Council. It is made up both of some of our physicians, a number of our clinicians, as well as we have a number of our patients, consumers, clients sitting with us at different periods of time to engage them in the process. And what we're really trying to do is make sure that we've got the same standard and the same measure across our entire enterprise. And then really trying to say, how do we make sure that the Quality Council, who's ultimately making the recommendations of standards, drives it down to the states? And then how do the states drive the information back up to the Quality Council so that we make it, we're continuing to be aligned and that we support both parts of the equation? Because no shock, quality then gets into areas of risk management and compliance. And so we've got those councils going at the same time. It really is about how do we interface and how do we connect those. And so this is the basic structure that we have. There are approximately across our enterprise 20 people that are invested in the Enterprise Quality Council and that are doing the work on a regular basis. We can flip to the next slide. What's really kind of fun for us is that as we look at some of our measurement strategies, is that we get to look at them from many different places. So for example, in to care, you know, our detox provider or our methadone clinic provider, our psychiatric hospital provider, our outpatient providers will all talk about it differently. And they'll say, well, you can't use that same measure. And the reality is we can. And we use it the same measure, just in slightly different ways. So in our detox, you know, we measure from the first phone call to when you actually get assigned to a bed in the facility. In our methadone clinic, it is phone call to first medication. And it's a fascinating measure to look at, because what we've seen is that some of our for-profit competitors have gotten really good at this measure because it does two things. One, it meets the client's demand and it optimizes the client's willingness to seek treatment. And so if you really decide you're ready to enter into a methadone clinic and its appropriate level of care, and you call a provider and they say, great, our intake is next Thursday. Well, what am I supposed to do between today and next Thursday to try and keep myself safe? Versus if you call the provider who says, great, can you show up today at 4 o'clock and we'll start the process. And hopefully by tomorrow, you'll be on an intervention that is making a difference. In our outpatient, it's the same. We're looking at first phone call to when do you have your first clinical intervention with one of our therapists. When we look at some of our safety and quality measures, we're really looking at we roll over a little bit into risk management here. So we look at and say, what are our medication errors? And I'll tell you, it is depending on what your service mix looks like, that can be a pretty frightening number. When I was part of a large health system in Massachusetts, we were putting up our medication errors. And the first time some people in the hospital saw it, they thought, oh my God, what are you doing? And I said, you have to look at the denominator. The number of medication administrations that we were doing, because we had 3 methadone clinics and we had 3 detoxes and a myriad of residential programs, we were administering over 1,000 medications on a daily basis. And so you start to look at that and say, oh yeah, and we had 3 errors in the course of a month. It was a really small ratio, but again, it was about explaining the context to people. The next one is pretty straightforward. Looking at the people that we serve. What we think we're providing often is not what our patients and our clients experience. And hearing from them is some of the most critical information. And the amount of resistance that we get to it is kind of interesting when staff say, well, wait a second, the patient doesn't really know what they're talking about. Want to know, it's their experience. I was recently at our operations in Florida and spent almost 2 weeks there. When I got back home, I've got an email from the hotel. They wanted to know about my experience. And because my first career was in hotel management, I actually took the time and responded to the general manager and told her about my experience. And I got another set of questions back from her. And it was really, I did it one because I actually liked the hotel where I was staying and they're doing a great job. And I wanted to give some feedback, but also just reinforcement for me to say, wow, you have to talk to, they use the term customer, we talk about our patients and our clients. It is critical to inform the care that we provide. We spend a fair amount of time in our organization on staff engagement and staff development. Again, because of the seat that I sit in, I often think, wow, everything's going really well. And then you talk to the frontline staff and they talk about what's working for them and what's not working for them. And what's amazing and wonderful and continually gets reinforced for me is that the values that I have and the goals that I have are often so clearly reflected in our frontline staff. And their frustration typically isn't with the management decisions we're making. It's about the barriers that we're putting up to them providing care and being able to engage the clients. And so talking to our staff is just as critical as talking to our patients. And it never ceases to amaze me what, kind of a weird way to talk about them, but what rock stars we often have at the front door who care about our clients and show up every day to take care of them. And then I think the transparency piece really just says, we're going to talk about what we're doing right, and we're going to talk about what we're doing wrong. One of the pieces that we've been focusing on lately is a root cause analysis. When we either have a critical event or we have a near miss, we do a root cause analysis. And there it really is to just put all the cards on the table. We're not looking to blame anybody. We're not looking to point a finger. We're looking to say, how do we do this better next time? How do we avoid this mistake? Where did we have a blind spot that we can remove for the future? And then it all gets wrapped up with kind of the process, the performance improvement projects. And that really is looking and saying, where are we today and how do we get better? So if our methadone clinic currently is at, not a number I love, we're currently at 6 days from phone call to admission. How fast and how hard can we push that? And I'll say, I'm not looking for them to get to 24 hours from phone call to medication tomorrow. But I'd like to see us move a day every couple months in shortening that cycle. And it's trying to figure out what are the pieces that are causing that delay. Is it about, do we have the right staffing? Do we have the right clinical partners from lab? Are we asking, or are our docs asking for tests that they might believe are good, but the data says actually to get to step 1, you don't necessarily need that step. And so part of what we do sometimes is educate our docs with some of our other docs who are more who have a better understanding of what the latest science is. We can go to the next slide. And we'll kick it back to Victor.
Yeah, that was terrific. The focus on patient experience, the focus on staff experience, and the process, and in effect, you've, I think, illustrated really well where to begin. I in this slide originally said we start with the patient experience. I think that is where we focus. I think that is where we start. But I would add, since doing this slide, to it, that you also focus on the data about performance. So in effect, if we begin to start with data that reflects our organization's performance, as well as data that reflects what the patient understands to be their experience, we have the right place to understand where we need to begin. The reference underneath talks about the ability, this whole area of where to begin and the patient experience, at least in NIATEX terms. And by the way, you know, NIATEX is the name that was derived from the demonstration and from the project that eventually SAMHSA supported with the Robert Wood Johnson Foundation that we did together over a long period of time. We've reached, I believe, over almost 7,000 treatment organizations in the United States with that approach. It's not unique. It's not, I'll get into this, but you know, it's essentially the Deming-based performance improvement. It's a very straightforward process, but you've got data. I mean, in what Shatterproof has fed back already. We know, for example, that 38% of the patients can't see someone for help when they want it. Seems to me that that's a number to begin to work with. We know that 60% of patients don't receive follow-up within 30 days of discharge. We know that only 35% of patients with opiate use disorders receive any kind of pharmacological intervention. We have data to begin to start with. Next slide, please. Principles are essentially, as I said, pretty straightforward. I think Kevin illustrated these in his description. We have customer and performance data to begin to work with. Relative to understanding the patient, I really encourage you to think about and to perform a walkthrough experience. I don't know how many of you have had that experience. It'd be interesting to know how many of you have actually done what in the NIATEX world was described as a walkthrough, which is essentially, you know, this was, it was designed and injected in the process by Dave Gustafson at the University of Wisconsin, who many of you know of. David is an industrial engineer. He's spent his whole career applying those principles of industrial engineering to the healthcare world. When probably 20 some odd years, more than that ago, he was asked by a hospital in Wisconsin to look at some problems that they were having in their cardiology department. he said, yeah, he would help them look at their workflows. But the first thing David did was literally had himself admitted as a cardiology patient in that hospital. He talks about lying on a gurney, looking at the ceiling, waiting for someone to come and see him. If you do a walkthrough, this isn't secret shopper. This is, you let staff know we're going to do a walkthrough, but we want staff to, in effect, perform and follow the procedures that they would normally follow. When we did applications for the original funding to support the process improvement projects, we asked, as part of the application process, programs, organizations, to actually do a walkthrough and write about their experience. It was eye-opening to most of them. Again, not because they saw things that were horrible, but they began to see what Kevin was describing as systemic, system-based obstacles. This isn't about malintended staff. This is about ways in which we organize our work that are not always leading us to getting the results that we want, that create impediments. So the focus on the patient, the focus on performance, the data available to both customer or patient and performance is where we really begin. And then the openness, the transparency that Kevin referred to relative to staff. What's the worst thing in an organization? The worst thing can happen in an organization is that the errors that are made are buried. I mean, how long are you going to keep patients, or how long are you going to keep patients well if performance errors are being hidden? And if we're not rewarding the revelation of malfunctions and the solution of those malfunctions, what's going to happen? Staff live in fear and they bury them. It's pretty straightforward. Learning from outside your organization, this is a fun activity. And this is what you can look to local industries and ask them how they address quality, be they manufacturing or other service organizations or other healthcare related institutions. Our introduction to this early on was with the Baldrige Award that was given at that time to the Ritz-Carlton hotels. That should not be a surprise, right? The Ritz-Carlton is supposed to be the epitome of good quality. And so, being a little brash and presumptuous, we in this treatment organization went to the Ritz-Carlton in Boston and said, would you help us as a struggling community-based organization with at that time probably 100 some odd beds of different levels of care to understand our patients better and respond better? What can we'd like to learn from you since you got this prestigious award? And they said, no, thank you. Oh, okay. However, down the street, there was a Marriott that we used to frequent for meetings and that kind of work. And you walk into that Marriott and there was always someone at the door that greeted you. Always. It was always someone then where you were handed off to that said, you know, how can I help you? Where are you going? There was always a response immediately when you sat down in that dining room. So we went to the Marriott and said, would you help us orient staff to customer service? And they said yes. And they spent their director of human resources the next year working with us in teams to around customer relations. a powerful leader with a powerful sponsor, meaning that you have the sanction and credibility. Again, I think Kevin addressed this pretty effectively. And finally, do something. Just do something. You've got the data. You understand the problem. You have the sanction to address it. Try something. Don't just analyze and analyze and analyze. Make a change. Track it. See what it does and do it again. So, next slide, please. I'm not going to spend time on this. I think that this is quite available. I think it'd probably be redundant. Our time may be better spent in some discussion, questions, back and forth, and some mutual learning. But this is essentially the simple model of act, know what, get a focus, get a measure, act, try something, look at what the result is, evaluate it, act again, make an adjustment, do it, and redo it. Next slide, please. Hello? Did someone? Okay. I think that spending a minute on why are we focusing on quality? I think maybe this is self-evident and we can go through it reasonably quickly, but this is where, in effect, I hope the passion that you have really comes through. You know, we're still only dealing with a little better than 1 in 10 people with this disorder. If there's no other reason, that should be an incredible motivator for us to think about quality. There was a point at which we dug deeper into that, both those that entered treatment as well as those that didn't have access to treatment, and tried to do some projections of the number of lives. You know, we talk about 70,000 lives lost for the with overdose for the opiate epidemic. Well, the total mortality rate is incredibly higher than that. It's not because that's not accounting from the alcohol and related deaths. So I mean, that's just, it saves lives, and we can do that. And you know, it's what the patient should have, right? I mean, they deserve it. They expect it. That's why they're coming. They're not coming for help for the fun of it. It's not an easy thing to do. It's not an easy thing. You know, people, one of the stigmas attached to addiction is this foolish notion that people are irresponsible. It's not easy to be addicted. It's hard work. It's not pleasant work either. Helen mentioned staff morale improvement. It's good for the organization culture. And it, you know, like it or not, it's good for the regulator and purchaser. It's value to the purchaser. And if you want to serve more people, you want to have a good relationship with your purchaser. And you want your purchaser to feel that they are getting value. There has been, again, an empirical analysis of this. It's referenced down at the bottom of this slide, an article that, a research project that did an evaluation of the impact of process improvement, particularly on staff, on patient retention, and references to the value dimension. Next slide, please. You heard about what Centerstone is doing. Here are a few other examples of quality improvement systems. One of the ones that really is impressive to me is the state of Connecticut, which has done this for a number of years and actually publishes an annual dashboard performance metrics that they track. And you can see it at this URL. And it publishes it both for individual providers as well as collectively, so you can benchmark. And I just wanted to, the last is, I mean, this is not just a national concern. The United Nations World Health Organization has an initiative that is focusing on improving quality through the establishment and orientation to treatment standards for drug use disorders. So this is something that you can pursue. I'd like you, if you would have examples that you'd like to share. I'd like to be able to do that in a few minutes along with questions. So you might begin to incorporate your interest and willingness to share an example in the chat function. I've just a couple more things I want to go over quickly. Next slide, please. After putting this together and reflecting a little bit, I said, you know, it would be probably not very responsible to talk about this topic and leave out the fact that we are in very different times. And I think those different times has generated a huge response on the part of treatment systems that I've seen. I have nothing but admiration and respect for the adjustments that I've seen. I've heard and spoken to many people, and the general theme is, gee, the changes that we've made, particularly around the the use of electronic communications, have been more positive than I thought, and we're probably going to keep a lot of them. And so the thinking about not only how the pandemic has affected patients in a negative way, which it has. There's many and growing indicators of an increase in opiate use and overdoses, as well as in alcohol sales and use. And so there's negative consequences that way. We know that you can't keep as many people in beds or in on-site and outpatient programs, et cetera, as you had before because of distancing requirements. But there's also positive things that you have done. And again, in the chat function, it'd be interesting. I would like to hear us have some discussion about that. Particularly, I would like to hear your thoughts on how the pandemic might affect what it is you want to track and measure and follow. So are there different standards and or measures to follow those standards that we should be thinking about as a result of operating in the context of a pandemic that will stay with us or not? Are there changes in the QI process, other than the fact that you can't meet together around a table, that as a result of this? I think your experience could really inform that. I'd like to hear something about your experience. Next slide, please. Last slide. So thank you for this opportunity and for sharing. We'll get into questions and as much discussion, particularly around examples of systems that you are using, and then adjustments that have been made relative to the pandemic. But I want to leave with two cautions. The first, and Kevin, I think sort of referenced this, and I want to underscore it. The first is we have a staff, you have a staff that is incredibly committed. It's usually pretty bright. It's probably more knowledgeable than we give them credit for. You know, people say we have a problem. Well, let's train the staff. You know, I don't know that training the staff is a good solution always. More often than not, my experience is the things we intend and want to happen fail to happen, not because of staff failure, but because of system failure, because the context in which they're working. You know, if we say we're only delivering methadone in a 2-hour window from 6 a.m. to 8 a.m. in the morning, I mean, that's a system issue. It's not staff that's blocking people. It's not, you know, it's not lack of knowledge of the effectiveness that's blocking people. It's our system that is how we've designed it. So the focus on systemic impediments to achieving the intended effect, you know, that taste of the ripe tomato, the system impediments to that intended effect are where we focus. And then the second and final parting thought is transparency. I have sat through and experienced, when Kevin talked about root cause analysis, I mean, as recent as a year ago, an opportunity to do a root cause analysis related to an opioid overdose that could have improved services, that was totally upended and thwarted because a person, an organization took the position that this was only going to result in blame and finger pointing. Bury it. Don't do it. It's transparency is our light that will make this get the intended effect, which is that we have people healthy, back with their families, connected to community, connected to work. So thank you again. Let's see where we are with our two themes. So Leah and Angad and Caroline, do we have some themes from those last two questions?
Yes. Thank you so much, Victor. First, I wanted to recap a few key points while folks are, go ahead and you can enter any questions you have in the chat function. Just wanted to recap some of what Kevin and Victor shared. So Kevin talked about the Quality Council at Centerstone, the importance of identifying a leader for quality improvement efforts, you know, key to have that leadership and involvement, as well as identifying an individual at the facility to act as a champion for those efforts. So working on analyzing the quality data, understanding where there are opportunities for improvement, and then pulling in the right staff at the facility. You know, obviously lots of folks involved in these QI efforts. Kevin also talked about how quality improvement is as simple as understanding where you are today and where you want to be next month. It's our hope that Atlas will be a useful resource in tracking those that ongoing quality improvement and making adjustments as needed. Victor shared some statistics that we're seeing in Atlas related to access, provision of medication, patient experience of care. These are all areas where we think there are opportunities to improve care, and we have the Atlas data that you all will be able to dig into and use for that purpose. Victor also mentioned the PDSA model, that Plan, Do, Study, Act as a rapid cycle process improvement model. This, many of you are familiar with this already, but this is one item you can learn more about on the Atlas Provider Resource page. This is also where we'll upload additional information and resources that our speakers refer to at both this session and at the additional sessions in the following months. Victor mentioned the impact of process improvement on both staff and patients. And we're really excited about, again, digging into that patient experience of care data and that feedback at one of our upcoming sessions, which Angad will share with you in a couple of slides here. And then discussing how to integrate that feedback into practice. Victor also highlighted the importance of building strong systems, and more important than ever these days, to mitigate the challenges that may interfere with your quality measurement efforts, not the least of which is, of course, COVID. So with that, I think I saw in the chat mention of some barriers providers are currently facing. I think that's a really important item to draw everyone's attention to. I would like to turn it over first to Carolyn, who will speak a little to the barriers analysis that we conducted, and then we can turn to some of those barriers identified in the chat, and we'll move to Q&A. Carolyn.
Great, thanks, Leah. Thank you both, Victor and Kevin. I'll just be quick and note, I saw a comment from Ann Constantino in the chat noting that there are barriers in terms of staffing and that can make it difficult to provide high quality care. So as a note, I note that for those of you who completed the treatment facility survey, there was a question on there about the barriers that you're encountering. And so divided into patient mix, workforce barriers, administrative barriers, and others. And to note that we have analyzed those. We're preparing a report right now. Certainly staffing is one of the major barriers that we're seeing in terms of, for instance, high staff turnover, or for instance, there's low reimbursement rates or low training. And so we are excited to share those with you all, hopefully in the coming months. And from there, we'll be deciding some of Shatterproof's policy work. So how can we work to remedy these barriers, and also encouraging our advocates to do the same. And so last but not least, Angad, I will hand it to you to close things out and start our discussion.
Thank you, Carolyn, Leah, and thank you to Victor and Kevin. What a great presentation and discussion on quality improvement, very informative. So as we move on, we wanted to provide a sneak preview of our second event in our CQI improvement learning series. On Tuesday, October 13th, we are convening a panel of industry professionals to discuss comprehensive care delivery in addiction treatment. So we have, I think, finalized the logistics, and please stay tuned as an invitation will be coming and forthcoming in the coming days. Next slide is, so if you're interested in bringing Atlas to your state, don't hesitate to reach out to us at atlas@shatterproof.org, or please contact myself, Carolyn, or Leah at our email addresses below. And just a few quick housekeeping notes before we get to the Q&A. As Carolyn mentioned at the beginning of the session, we did record today's webinar, and we'll be sending it out. So please be on the lookout for that. And we encourage you to visit treatmentatlas.org, and specifically the provider resources page there as well. So before we open up for questions and answers, I wanted to just sort of go back to the chat. I did see some great examples of quality improvement work, and just wanted to quickly highlight some of the responses. So Helen, I know you mentioned that you think of your quote unquote front door metrics in your outpatient realm. Having telehealth as an option has been amazing for both the population with SDH issues, transportation, childcare, et cetera, and also the group that is a little higher functioning and working full time. They are able to access treatment more aligned with their schedule. And then you mentioned on a broader note, not COVID related, that you're interested in experience and ideas around change management versus strategies like ODSA, and that we can have the tools, but if they are not functioning within a change culture, the effect will always be limited. I think that's a great point. And I think it gets to what Victor was saying in terms of staff failure versus system failure. The next quick item that we have here in the chat, take-home methadone is in residential treatment with up to 28 doses allowed under SAMHSA waiver due to COVID-19. In collaboration with residential providers, we are developing guidelines for the storage, management, and distribution of methadone in this treatment setting. Another item came in mentioning that someone has heard of a number of improvements pushed by COVID disasters, BMC OBAT clinic director decided they must provide 24/7 access, and that she put up her own phone number to start it off. Wow, that's great, leading by example. Mary Crockett, first, hello to Victor and Kevin, who she has known since 1993. She says last year she conducted a quality and safety round to every one of the 45 or so programs at her agency, including staff and client interviews. With the pandemic, things have changed a bit, she said. And 2 weeks ago, she sent out an agency-wide quality and safety survey, and she's currently in the process of sifting through over 260 responses from staff. Wow, that's great. More staff and client interviews are still happening with video meetings. And then the last two, and then, Victor, Kevin, would love to see if you guys have any comments. Someone mentioned serious challenges with the workforce all the way through during COVID has been heightened due to high-risk staff. And then Victor, you mentioned you would love to discuss the workforce development approaches.
There were several people that put on the chat the issue of workforce, and absolutely no question that is problematic. In terms of recruitment, it's across the board. I don't think there's a quick solution, quick fix to workforce. I am a strong believer that there is an intermediate time solution to workforce, and that is essentially based on 2 or 3 principles. One is you draw from your own. That is, we have people involved in this field in a variety of roles and ways that are that have a capacity with the right support and credentialing to do more than they're doing. And so rather than looking outside, the first principle is we look inside for our feeder system. The second principle is that this is something that is not, it's difficult to solve agency by agency. And if there's any issue that shouts, screams out for collaboration between organizations that otherwise compete, it's workforce development, where you join together to get the size and scope to be able to leverage what you need for the education and credentialing process. And the third principle is that we need to connect with our public community college and state college systems to provide that component, but not provide it in the basis that they on their terms, but to begin to upend their teaching and learning processes as much as we are upending our delivery systems. That in effect, we have a staff that is, that through the work they do, knows more than what they may be aware of. Or let me put it this way, through the work they do, that provides the curriculum, the content that you can extract out learning principles. And that means faculty have to be able to turn their head around and not teach from a book or from a theory, but to be able to learn to teach from experience. All of those things are possible. Those 3 things that you can draw from inside, that you collaborate to get the size and scope, and that you work with educational institutions for a different basis. Those are things that our state leaders, that our association leaders, that teams together can begin to stimulate.
Thanks for that, Victor.
My 2 cents, 3 cents.
Very, very insightful, and I like the draw from inside approach as well. I think that's incredibly important. So at this time, we can open it up for questions and answers. So I think the lines will be unmuted. So if you have a question, please I was going to say raise your hand, but or just speak your question. Are the lines unmuted? I think they're still muted.
Oh, I didn't unmute everybody just because there's 99 participants, so we might get a lot of feedback, but you are able to unmute your own line. So I invite you to do so and jump in or contribute to the chat if you're more comfortable.
Hi, it's Ann Constantino. I just put my comment in the chat. I think workforce development is a huge issue, and I agree with all the strategies that have been discussed and the need to collaborate and train and everything else that we're talking about. But there's a fundamental problem, which is the wages that are paid to the front line for the work that they do, which is life-saving crisis work constantly, with pressure coming from all sides. And these are, in many cases, licensed professionals with advanced degrees that we pay less than support staff get in other industries. So we train, and out. And my point is that once we train staff and they have horizon experience, I'll speak for myself, they're very marketable, and they can go to health insurance companies, they can go to other industries. Yes, they have a passion for the work, but the work is not adequately funded or reimbursed. And that my main interest in Shatterproof is to legitimize our field so that we can get the reimbursement rates that are well-deserved for our staff, and so that we can pay them more money. That's the point. All the rest of this is nice. But if it doesn't fundamentally change our industry, we're always going to be where we are.
And I would make one comment in response. Having been in the field for quite some time now, I completely agree. What's been interesting is I recently hired a new Chief Human Resource Officer. He came to us from FedEx, where he was the Chief Human Resource Officer. And his first point of analysis is looking at our turnover and looking at the spend that we have because of turnover. And what's interesting is he is making recommendations on a regular basis of how we get to market at the 50th percentile for our staff. And it frightens the heck out of all the CEOs, because it looks like we're just throwing money that we don't have coming in the door. But as we save on turnover, we're actually seeing a longer retention period. That's the short-term fix until we get the appropriate rates of reimbursement, so that we really don't have to always be shaving around the edges.
Well, I want to yes, but you.
Okay.
Yes, but, because of course we've analyzed that. But the truth is that as people advance in their career and they get experience, we have to pay them more. There's a fundamental problem between reimbursement and cost of service. We have low turnover rates in our industry. We're a best place to work in New York State. We work hard on corporate culture. We do tons of training. That being said, reimbursement rates, and we're low cost, we're big enough to be low cost. Our reimbursement rates do not cover the cost of comprehensive care, because it's more than just a patient and a therapist. It's all of the coordination, it's all the follow-up work, it's everything that we've talked about here. It's quality improvement, it's training, it's all of that. It's technology. So yes. And I'm going to tell you, you can't talk about a strategy that I have not. I've done this for a long time too. You can't mention a strategy that I don't know about. But that fundamental problem exists, and it needs to be dealt with. And we can't talk it away. We have to acknowledge it.
Yeah.
Exactly right.
Yeah.
Thank you.
Yeah, I agree.
And oh, I was going to say, Anna Woolen, I noticed that you unmuted yourself. Did you want to jump in?
Sure. So just to follow up on the comments that folks have been made, I mean, that folks have made, this has been an ongoing struggle, I think, for all of us, not just substance use disorder, but behavioral health care in general across this country. And it's going to take a lot of work, a lot of legislation, I think, to make some real difference in order for us to provide real care. Because I oversee I oversee 36 hospitals in the country, and among those 36 hospitals, we have 2 detox units. And the idea of detox, if somebody just medically necessary, somebody comes in, you give them medication, they go back out, and you only get a handful of days to do any real work where recovery is concerned. What's the point? We need to be able to provide real care for these people, and we don't get, the reimbursement rates are absurd. And until we can make some change at a legislative level, I don't know that we're going to move the needle on any of this. I really don't. We need the staff to follow people outpatient when our patients leave, whether they leave inpatient psychiatry or inpatient detox. I would love to have a group of people that calls all of these people, if not every day, every other day. How are you doing? What did you learn? Is there anything we can reinforce? Do you have a way to get to your next appointment? Can we get you an Uber to get you to your next appointment? I mean, unless we have those kinds of resources, these poor people, and you know what? The amazing thing to me is that the patient experience results we get from our psych units and our substance abuse units are so high because they're so grateful to get any amount of care. And it's just sad. It's very sad.
Hi, this is Connie Peters in Massachusetts, and I know rates are horrible. They're horrible here as well. We're with the Trade Association for Behavioral Health Care, representing the providers of mental health and addiction treatment. We all do a lot of legislative advocacy work on rates. It's really one of our key issues, and we've had some success. We got legislation passed that they review our rates every 2 years, but it took a legislative effort with a lot of support to get this through, because this, I don't know about other states, but in Massachusetts, the state set rates sometimes would go 10 years before they even looked at them for addiction treatment. So I just have to put this out there. I'm sure all the other states are in this situation, but unless the federal government comes up with more COVID-19 emergency funding to bail out the states, we're looking at huge cuts across all the human service systems, including ours. And I appreciate all this quality talk, but I'm terrified about this situation. Our state budget, they did a continuing resolution through the end of October, and they're talking about a 20% cut to our whole state budget, which would impact human services primarily. I'm just raising it.
Yeah, and I'm in Massachusetts as well, and I know what our struggles are. And I do agree, though, that quality is extremely important in the care of substance use disorder, only because a lot of the care is so traditional. I remember being not too long ago, hearing counselors tell patients, take the cotton out of your ears and put it in your mouth. I mean, that kind of an attitude it's got to go away. And I remember trying to make a change to one little thing we were doing, and everybody was up in arms because, quote, she wanted to change the big book. And it was like the end of the world. But we've got to change the old ways of the way we're treating these people. And I love the whole Shatterproof thing. I love that this finally came out, that we're finally going to do something based in evidence for our patients.
Thank you, Anna and Connie, both so much. I appreciate your comments. I was going to say, I know that we have 2 last comments, and we are over time, so if you do need to hop, I invite you to do so. But first, I will call on Robert Musacchio and then Frank McCory. And thank you for those who have to hop. Thank you so much for joining us. Please send us an email at atlas@Shatterproof if there's more that you want to discuss, if there's more that you hope that we cover in the series. We'll also send out a survey afterwards to get your sense of how the session went, how we can improve for the next one. And Kevin just messaged me noting that he will have to run, and Victor, thank you, and Kevin both so much. So Robert, I will hand it to you, and then Frank, and then we'll close out for today. Oh, Robert, you
Robert's
just muted yourself.
muted.
You were unmuted.
Yeah, no, I didn't have to comment.
There we go.
Sorry. No, I didn't have a comment.
No, you're totally fine. I thought you were going to
I didn't realize
that,
that if I was muted or unmuted, I had a comment to make. Sorry about that.
Oh, no, I was just noticing that's how it normally goes. That's why.
Yeah.
In that case,
Okay.
Frank, I will turn it to you for our last
Great, and a quick shout out to Victor. It's good to see you again, old friend, and
Yes,
thank you
indeed.
for the shout out to me.
Yeah.
I was going to comment because on Ann's comment, and which is really this kind of diminished sense of the value of substance use care, and it's reflected not just in stigma, but really in rates, in funding. And part of the issue is, I think, is it continued the kind of myopic view of what substance use treatment actually does. So savings in the criminal justice system, savings in the welfare system, savings in the child welfare system are not considered valuable in terms of, or reimbursable. That should be treatment should be funded for the costs that get saved in those segments, those sections of the economy and of government. And you could see, I mean, as far as healthcare with managed care and Medicaid managed care, you can see that avoiding the ER has come to allow for some negotiation of treatment having some impact on healthcare costs. Certainly not enough, because the impact is much greater, as the research shows, that the savings accrue not just to the individual, but to the family in terms of healthcare costs. So there's work to be done there, but there's really this diminished perception of the value of substance use care because of the impact that we have on other systems that is not recognized in the funding that we're given to do the work. And so I think it is an important point. And of course, to raise this in the context of the drastic cuts that are awaiting us over the next 2 years without massive federal intervention, maybe it's really, maybe it's not the best time to talk about it, but I think it's worth just recognizing that we're doing tremendous work that is not paid for and that benefits the economy and the society, but that is not recognized for that. So I just wanted to get my 2 cents in at the end as well.
Amen. Amen. Yeah.
All right. Well, Frank, thank you for that last comment and question. Appreciate it. And I know as we talk and engage with many of our various stakeholders, we are cognizant of the many barriers and are eager to continue to work with the states and providers in addressing those barriers in our policy work. So, but this has been I think a very good Q&A and a good point to wrap up. So first, our apologies. We are about 10 minutes over. If folks have any additional questions, please don't hesitate to reach out to us at atlas@shatterproof.org. And we look forward to our next session in October and hope you can join us then. And special thanks